Good evening, everyone, and welcome to HIPECtreatment.com's Facebook Live event. We're honored tonight to have Dr. Jesus Esquivel, a surgical oncologist at Beebe Healthcare in Lewes, Delaware.
Thank you, Mr. Keeling. I don't know how many people are there, but it is a pleasure to join you in this new version, 2023. So for those of you who do not know me, I came from Mexico and met Dr. Paul Sugarbaker in 1989, so a long time ago. Then I went to New York to do my residency and then went back with Dr. Sugarbaker in 1997 and spent a total of 7 years there working with him. And then after that, I went to St. Agnes in Baltimore, and then Philadelphia, and more recently left Maryland to be here in Lewes, Delaware, where my partner, Dr. Spellman, started the HIPEC program about 15 years ago. So I've been doing HIPEC for quite a long time.
How does HIPEC really work? A lot of people ask it, is it the cytoreductive surgery? Is it the HIPEC? Is it the combination of the two? In your opinion, how does this work? What is the mechanism?
No, that's a great question. I want to make it very clear. So HIPEC by itself offers some treatment for some patients. We sometimes do just the HIPEC without any surgery, and I'll expand that more in a moment. But traditionally, HIPEC is part of this comprehensive multidisciplinary treatment that involves cytoreductive surgery to remove all the tumor that is visible, and the ideal target of the heated chemotherapy is to target small microscopic residual disease. So that means cells that are floating throughout the abdomen and pelvis, they need to attach to develop a tumor nodule and then develop a blood supply, and HIPEC is very good at preventing that. How does it work? Well, it's a combination of heat. Heat by itself at these temperatures of 42 degrees has the capability of killing cancer cells. Radiation is a perfect example. It's just concentrated heat at a very high degree. Then the second part of HIPEC is the chemotherapy itself, which also kills cancer cells, and it's supersized, if you will, or potentiated by warming it up. So not all the chemotherapeutic agents are made to be used during HIPEC because they don't have any synergy with the heat. And the third component of the heated part of the treatment is that any of those tumor nodules will be softened up by the heat and will increase the depth of penetration of the heated chemotherapy. So if you think of a tumor nodule, when you give HIPEC, there is the outer portion of the tumor nodule being bathed on chemotherapy, and then there is a second component, which is that chemotherapy gets absorbed and through the blood vessels attacks the inner core of that particular tumor nodule. So that's briefly how HIPEC works.
Question coming in, Dr. Esquivel. How many times can a person receive HIPEC?
So there is no limit. HIPEC is well tolerated. We use nowadays anti-adhesion cellulose layers, so to prevent scar from the operations. Many years ago, literally 3 decades ago, I think it was in 1991, I published a paper with Dr. Sugarbaker on repeat HIPECs, and we did it up to 5 times. In other words, I think that the limiting factor is going to be the amount of adhesions or the non-response to the therapy. It's not that there's something in particular like intravenous chemotherapy that the toxicity gets too high. In this case, the limiting factor is the biology of the tumor, number one, and number two, the distribution in the abdomen and pelvis because of adhesions.
Okay, another question coming in. What are the long-term findings in terms of longevity after HIPEC versus no HIPEC?
So that has been, the only way to answer that is has to be very specific to the particular diagnosis. We know, for example, that in ovarian cancer, this has been studied in what we call a prospective randomized fashion, meaning that all the patients went to the operating room, and right after completing the cytoreductive component, half of those patients received HIPEC and the other half did not. And that we have not been able to study it that way in the United States because it's quite difficult. But for ovarian cancer in particular, the 90 minutes of adding HIPEC after the surgery translated somewhere between an additional 12 to 15 months of survival, just for 90 minutes. So a very significant component, which allows the patient to be eligible to receive therapies that are being developed during that particular time process.
There was recently, a couple years back, a study done in France, a French study. It's called Prodigy Study. What do you think about that study?
So that study is probably the most common study mentioned every time you discuss HIPEC in any meeting around the world. And it has had significant implications. I'll just be very brief. In this case, that's exactly just like the ovarian cancer study that I mentioned. The idea was to evaluate what was the added benefit of HIPEC after having a complete cytoreduction for patients with colon cancer. And we say, you know, in the scientific world that you design a trial, but eventually you don't get to do the trial that you want. You end up doing the trial that you can complete. And that was part of the problem of this French study called the Prodigy 7, in which the idea was what I described, to take all the patients, treat them in a uniform fashion, and the only variable being HIPEC or no HIPEC. However, there were a lot of problems since the beginning because patients did not want to participate, medical oncologists did not want to refer those patients, and so the inclusion criteria start getting a little bit more lax. And rather than said, okay, all patients are going to receive 3 cycles of systemic chemotherapy and then go to HIPEC, they changed that criteria to, okay, as long as they get 3 cycles, as long as they get 6 cycles, those can be 3 before, 3 after, 6 before, or 6 after. So now you're not comparing patients that are exactly of the same category. In addition, there was a crossover. That means that patients that were in the non-HIPEC group were allowed to break the protocol, and not by the French, but mostly by Belgium. They went and other places and got HIPEC after they had a recurrence. But since the study is in what we call an intention to treat, those patients that eventually got HIPEC were evaluated like they didn't get HIPEC. So there were quite a few variables that were not exactly the same. In addition, in order to have more patients, they included centers that, contributed with very small number of patients, just a handful of patients over that long study period, while other centers included hundreds of patients. So the experience was not the same. So fast forward to the punchline. The most important part of that study, in my opinion, is that both groups had a very significant survival of about 41 months, even the ones that didn't get HIPEC. And that shows that there is a role for surgery in this particular group of patients. On the other hand, these findings in countries like Germany put a moratorium in the ability to do HIPEC in this particular group of patients. But no worries, the Spaniards and now the French again are coming to the rescue by repeating the trial and using mitomycin C for 90 minutes instead of oxaliplatin, that was the drug used on the French study, which is a drug that doesn't have any activity as a single agent. Neither does HIPEC for 30 minutes. So a lot of questions about the trial, and I think that is very difficult to conclude any definitive decision based on only one study.
Dr. Esquivel, we have another question coming in. This viewer had appendiceal cancer, diagnosed with appendiceal cancer, gallbladder removed, and has had chronic diarrhea since HIPEC. Is this a common side effect of HIPEC?
It's not. The side effects of HIPEC are very small, and they're all going to be seen immediately after the operation. I don't know if this particular patient, if he or she had also a bowel resection. Sometimes, for patients with a large tumor burden from appendiceal tumors, we do a right colectomy and a left colectomy, and sometimes even a small bowel. And so the amount of bowel remaining can determine having diarrhea or not. In addition, some patients, when you take out the gallbladder, which the purpose of the gallbladder is to store bile and empty that bile into the intestines when you eat, they are not able to store it there anymore. And so not having the gallbladder can make the bile that is made in the liver go directly into the intestine, and some of those patients will have diarrhea. My recommendation is to see a gastroenterologist, and it's possible that he or she already did that and tried cholestyramine or Questran, some other medications to try to slow down the diarrhea. But even if the patient had a significant amount of bowel resection, I think that seeing a gastroenterologist and quickly moving to even another center. For example, I know that Georgetown University Hospital in Washington, D.C. has a small bowel rehabilitation clinic because they run an intestinal transplantation system there by the Dr. Thomas Fishbein. And he was telling me the other day that his team has been successful at getting 50% of the patients off TPN just by rehabilitating the small bowel without any transplantation. So I would encourage that particular patient, step one, get a gastroenterologist, and step two, if that has been done already and is not working, to reach out to the Georgetown team. The last name is Fishbein.
What is the role of HIPEC in controlling ascites?
Yeah, that was the part that I said I was going to answer and I didn't at the beginning. Sometimes, like I said, we do HIPEC with the intention of drying out the ascites. I have done it for patients that have carcinomatosis from breast cancer, which obviously is not, we don't do cytoreduction in those kind of patients. But when we study how effective the HIPEC is to drying out the ascites, overall, it was over 75% of the time. You may remember I spent some time also with Dr. Sardi, and I think one time we did it for a patient that had intractable ascites from prostate cancer. So the goal of the HIPEC in those particular cases is to target the area that has small tumor nodules, not bulky disease. HIPEC penetration is limited, but in those patients that sometimes have just a miliary distribution, I usually describe it as somebody opened up the patient and just threw a bunch of kosher cooking salt in there and splashed it all over. So when you have a small tumor nodules and ascites, that is a perfect target for the HIPEC.
Now, as far as HIPEC, is it normal to have ascites after HIPEC?
If you have ascites after you have had treatment, that just means that the treatment didn't work or the disease has come back. Ascites by itself, you can see it sometimes in the absence of tumor, and it's more like a consequence of transecting what's called the thoracic duct during the surgery. but that would be very unusual, and it's kind of like a milky ascites. But when you have ascites that needs to be tapped frequently after treatment, then that just means that the treatment did not work.
A question coming in, what typically is the cost of a HIPEC procedure?
That varies tremendously from institution to institution, and everything is related mostly to the hospitalization. And I break it down to a small, medium, and large. If you have a small HIPEC, and as I am a big proponent sometimes of even doing laparoscopic procedures, when we did that, those patients, for example, have a right colectomy, an omentectomy, a limited peritonectomy, and HIPEC, and they spent about 4 days in the hospital. When we kept track of those costs at a small community hospital, it was about $30,000. If you go to a big institution, and like we used to do in the past, and have to do an open procedure that takes 12 hours and you spend 3 weeks in the hospital, the tab for those patients used to be about $250,000. But I would say that on average, for a community hospital, it's probably going to be around $80,000 plus. Are
there any new indications for HIPEC?
So that's a great question, and I was hoping that somebody would ask that. I'll tell you just in 3 or 4 minutes the history of HIPEC. HIPEC was for the first time done only in 1979, so just coming up on 43 years, and it was done by Dr. Spratt at the University of Louisville, Kentucky. And he was actually working on studying this on dogs. And there was a wealthy Japanese patient that had Pseudomyxoma. He was 47 years old, and he thought that this was an appropriate treatment for him. And so Dr. Spratt did this, and that was the first HIPEC. And so since then, as you know, there has been quite a different ways to deliver the HIPEC. When I started doing this, we had to put together 27 connectors to be able to do a HIPEC on what I used to call the Home Depot version machine. And then companies like Viacirc, and then later on other ones joined and developed a commercially available machine. And at that time, the only thing that was indicated was for appendiceal tumors. And that was dictated basically by the insurance companies. We did it for other indications, but you can always use as a gauge of how indicated the therapy is by 2 things. Is the insurance paying for this? And is it part of what we call the NCCN, the National Comprehensive Cancer Network guidelines? And at that time, like I said, it was not on any guidelines. It was not approved for any insurance. And later on, it was approved for appendix and for peritoneal mesothelioma. And the reason was because there were no systemic chemotherapy that was good for those particular 2 diagnoses. Since then, as of today, I can tell you that the NCCN has approved the use of HIPEC for ovarian cancer, appendix cancer, peritoneal mesothelioma, and colon cancer in selected cases. So those are the indications that are being done in a much routine basis. Since then, we have kind of like extrapolated to other disease processes like small bowel cancer and tumors that are less common, but that have peritoneal disease. So I would say that the indications and the acceptance by the medical oncology community are growing. It's frequently done for patients that have gastric cancer. And I think that the problem with gastric cancer is that it presents at a much late stage with significant peritoneal disease. But in other countries, like in Japan, they're identifying these patients at an early stage and are including HIPEC as part of their treatment.
Another question coming is HIPEC the first line of treatment, or is it after other treatments have failed?
That's a very important question, because I used to write frequently that the most important part and the most important thing that we can do to answer this question and to determine when HIPEC should be a component of the treatment of a particular patient is to have what we call a multidisciplinary tumor board discussion. And we recently published a paper, like this month or last month in January, I would say. What are we going to do with patients in the state of Delaware? The state of Delaware has 1 million people and only has 2 HIPEC centers, one in the north, one in the south. And so we are guaranteeing that all these patients are going to be discussed at a multidisciplinary tumor board, and the timing of HIPEC is going to depend on the diagnosis. If it's for gastric cancer, those patients are going to get chemotherapy first. If they have a good response, they will get HIPEC. In ovarian and in colon cancer, if the patients are candidates for upfront surgery, we are going to be doing HIPEC upfront and then complete the treatment with more intravenous chemotherapy. That's going to be for patients with colon cancer. And while we don't have a consensus statement a published consensus statement, that's going to be also done for patients with ovarian cancer, as it is recommended by the National Comprehensive Cancer Network guidelines. So the bottom line, it depends. If the patient is fit for surgery and the surgeon can remove all the tumor, HIPEC should be done up front.
In ovarian cancer, what is the average length of time before recurrence?
Most of the patients that experience a recurrence is going to be in the first 18 months. For colon, if you were treated for colon cancer with carcinomatosis, unfortunately, the time to recurrence is going to be somewhere between 9 and 12 months. What determines where the patient has their HIPEC? Because at that time, we have very limited centers. And believe it or not, I was at that time in Baltimore, and my #1 referring center was from California. So patients will have to travel, 3,000 miles to come and have their HIPEC. But I think that the recommendation remains the same. The question #1 to ask is going to be, who is your surgeon and how many HIPEC cases has he or she done? And is the hospital, how long have they been doing HIPEC? I think that the very vast majority of patients, without having to travel 1,000 miles, are going to be able to find a center that has that particular area of expertise. And I also think that we, as the healthcare providers, are continuously trying to open more centers because more and more patients are being identified. Just as a comment on a study that I am currently working, in 2022, Beebe Healthcare is my hospital here in Lewis, and it's a small community hospital with a total number of beds of a little less than 200. And we had 11 new patients that came through the emergency room with appendicitis, underwent an appendectomy, and were diagnosed with a mucinous appendiceal tumor. So there's no question that appendix cancer is on the rise. We're seeing that more and more. And I think that consequently, we have to encourage to have a champion on peritoneal surface malignancies at any hospital that is doing other type of oncological big operations.
What is the best way to treat pseudomyxoma with chemo, before or after HIPEC?
On the true pseudomyxoma, which means that this is not an invasive cancer, but rather a massive dissemination of a mucinous, what we call the jelly belly, there is no role for those patients receiving systemic therapy. The treatment has been and continues to be cytoreduction and HIPEC. There is a very recent study published by the group of MD Anderson in which demonstrated that true pseudomyxomas, now I got to be very careful, true pseudomyxomas, not every mucinous appendix tumor is pseudomyxoma, but if you have a true pseudomyxoma, this particular study of MD Anderson has confirmed in a more scientific basis our observation for the last 30 years that there is no role for chemotherapy. On the other hand, if you have a mucinous tumor that is not pseudomyxoma, then the approach is if you can remove it all with surgery up front, then you should do so. If it is a signet ring component or a poorly differentiated mucinous adenocarcinoma that has a significant burden of disease, those patients should have systemic therapy first. And then if they have a good response, then they should go into surgery.
I understand that this treatment would not be suitable to primary peritoneal cancer patients who have had a metastatic spot. Is that true?
Well, it depends on what the metastatic spot is. Primary peritoneal malignancies are uncommon, but the classic one that we have on both sexes would be primary malignant peritoneal mesothelioma, and the treatment for that is cytoreduction and HIPEC. That is part, again, of the National Comprehensive Cancer Network guidelines. Ovarian cancer, in general, now is being determined as one group that is called as gynecological malignancies, whether you have ovarian cancer, fallopian tube cancer, or primary peritoneal cancer in a woman, because there has never been a male described with primary peritoneal cancer other than mesothelioma, are being treated the same way with cytoreduction and HIPEC. Now, some of these patients, even with colon cancer, can have metastatic deposits to the liver, which is not carcinomatosis, is tumor that has spread through the blood, and we have growing inclusion criteria. For example, if that is the case and you can have all the peritoneal metastases removed, we recommend that those patients can have up to 3 liver metastases removed at the time of the cytoreduction. On the other hand, if you have 8 or 10 and you require a major hepatectomy, then we don't recommend to do cytoreduction and HIPEC on those patients. But more and more patients with what we call a stage 4 ovarian cancer that has disease in the pleura is not a contraindication to treat the abdomen, because what gets patients into trouble is the peritoneal metastasis.
How can a person get diagnosed with appendix cancer before it's too late?
What we need is a little bit more time. Now, let me expand on that. I wrote a paper also many, many years ago in the presentation of patients with pseudomyxoma. And believe it or not, the most common form of presentation for a man was an enlarging belly, you know, because patients would think that they were getting old, that they were drinking too many beers and wouldn't do anything about it. The most common form of presentation on a woman was an ovarian mass, and at that time, the very, very vast majority, if not all of them, would be treated as ovarian cancer. But thanks to a lot of patient advocates, the number one of them, which was the queen of pseudomyxoma, Gabriella Graham, rest in peace, a lot of work has been done, and I personally think that it's very hard to get diagnosed with appendix cancer nowadays and not be referred to a patient, to a surgeon that does HIPEC. And I can tell you that we're seeing these referrals more and more at an earlier stage. Having said that, we still continue to see a patient that went to the ER, they thought they had appendicitis, but they were not sure that because there was no inflammation around the appendix, even though the appendix looked abnormal. they were treated with antibiotics just to come back 18 months later with a belly full of cancer. And so we are still failing a few patients, but I think that the number of patients that are going to develop appendix cancer and are going to present at a late stage is diminishing every year. And hopefully it will be as close to zero as possible, but it won't be zero. But a tremendous progress has been made in that particular situation.
Okay, Dr. Esquivel, I don't see any more questions coming in. You have any closing statements you'd like to make before we adjourn?
Yes, a couple of statements. In September was the Ovarian Cancer Awareness Month, and I was part of a lecture to raise awareness of ovarian cancer. And I think that if you are a patient with ovarian cancer, your treating physician has to tell you why you are not a candidate for HIPEC. If he or she cannot tell you, then we strongly believe that every patient with ovarian cancer has to be seen by a person that does HIPEC as part of their treatment. And nowadays, I think that we have an increasing number of centers that are doing this. And yes, you may have to go for a field trip. Last week, I did a HIPEC for ovarian cancer in a patient from Mexico because she was at a particular center that didn't do HIPECs. And she came all the way here to Lewis, Delaware to have her procedure done. So that would be one recommendation or one statement. But the most important one would be that every single patient with carcinomatosis or peritoneal metastasis, which is the term that we prefer, needs to be discussed at a multidisciplinary tumor board where a surgeon is present.
Dr. Esquivel, I want to thank you very much for your time. It was a great presentation. A lot of questions were asked, a lot of good answers. And again, thank you for your time and your expertise.
Anytime. And thank you to all the patients that join in or caregivers trying to find treatment for their patient. There is someone not too far from home that can help you. Thank you.